So I just want to start way back when in 2018. This is the first CT that I have from the archives. And as you can see here, as I scroll through, the liver looks clean. There's nothing going on in the liver. And then in 2000, this person was followed for renal calculi, hydronephrosis, recurrent UTIs, etc. And that's why we have so many CTs in our system. And then this is from 2019. As you can see here, there's a small hypodensity that has appeared in the liver. And we did notice it, we commented on it, but as you can see, it's so non-specific, don't know what it is. And then, kidney issues are ongoing, there's some scarring going on. So that's the liver finding. And I'll come back to one of the take-home messages subsequently. So following that, then I have, a few years later, I have an MRCP in the system. The MRCP was performed for relevant reasons, right upper quadrant pain, fever. And then as you can see, there is this lesion in segment 5 that has appeared. And if we compare to the CT, that tiny hypodensity has now enlarged in size. I'm just going to get rid of the markings. On T2 is—
Sorry, patient doesn't have history of like mucinous adenosine elsewhere?
No.
This is all new? Okay.
This is new. And the reason we have many CTs was for calculus disease and recurrent UTIs. So anyway, on T2, this is predominantly hyperintense. You can see there are some thin T2 hypo-intense septations within this lesion. There is no restricted diffusion. There is T2 shine through. Sorry, I have another MR up here, but okay. And on the post-contrast images, here is an arterial phase. So you do see some enhancement within the septations. These were not bright. There was no intrinsic T1 bright signal on the pre-contrast images. No enhancing nodules, but some thin septations, enhancing thin septations. This is an MRCP image just because there were gallstones and choledocholitis that was treated. And then subsequently, there was another MRI at a short interval that was performed. And, in 6 months, this lesion has continued to increase in size. So at this point, any differentials that come to your mind?
Sorry, can you keep scrolling while
Yes.
we discuss? Because I want to look to see if there's septation. So at that paper that Cookie and Sudarka wrote, talking about how do you separate like an MCN from a biliary cyst, right? So like lobulated margins are usually good for biliary cyst, but you gotta look at the septations. Like if it goes to that marginated indentation, then that's fine. But if it goes to an area that's not indenting, like I see lots of septations that are not. So then you think about MCN. So and then
IPNB.
Was there a new ductal DIL? I thought there was one of the ducts got a little bit chunkier.
Yes, that's a good point that you bring up, and I'll show you the coronal here. So this lesion seems to be very isolated. It doesn't communicate with any intrahepatic bile ducts. There is ductal dilation, but that was secondary to gallstones and obstructing choledocholitis. Then there was a stricture that was formed subsequently, developed subsequently, but there was no obvious communication of this cystic mass with, and that's what Aarti is trying to point out. IPNBs, how do you separate MCNs, mucinous cystic neoplasms, from intraductal, IPNBs, essentially neoplasms of the bile duct? The latter shows communication, the former does not communicate.
But for IPNB, I don't think you always see the communication, because there's a couple of types, and one is called like the cystic type. Yeah. And it doesn't necessarily look like it's forming along the bile duct or communicating.
Yeah, right. But this one, those, however, tend to be in the vicinity, at least. And this one is like far away in the periphery. Also, this is the right lobe. I read commonly that MCNs are more common in the left, but I don't know how often they follow that rule.
Yeah, that was what I was wondering, because usually we say left, like segment 4.
Yes.
And then also they should have a capsule. So shouldn't have as much of a lobulated edge because they'll have the ovarian stroma capsule.
Yes.
But I do agree with Nelly that like the shape, like the rounded shape and the septa and the lack of like affiliation with a major bile duct does look more like an MCN, but I
I'm
feel like
gonna share Cookie's paper, Sudarka's paper when you finish anew,
Okay.
so we can review the cartoon because I think that's really helpful.
Sure. So then let me show you an ultrasound. So they went to surgery, rightly so. And here is an intra-op ultrasound, which has a very interesting look. You know, if you remove this and put this in the ovary or some other part of the body,
a kind of caucus.
that's one good thought. But as you get, you know, these thin septations are all over. Echinococcus tends to be more, well, it can present in any way, but more commonly you have daughter cysts that are distributed uniformly in the periphery, so on and so forth. Yes, that's a good thought. Anything else? No color flow within the, well, we see something in the septation, no solid enhancing nodularity. But anyhow, so we were, our top choice was MCN, mucinous cystic neoplasm, because we excluded all other possibilities, and that's what we came up to. Any which way, this had to come out since it was growing fairly rapidly. And the final path on this was isolated hepatic cystic well-differentiated neuroendocrine tumor.
What?
And I know, and there was lymphovascular invasion present. Now I remember presenting a primary hepatic neuroendocrine tumor here last year or something like that, but that had more solid components in it. And when I looked through literature for hepatic neuroendocrine tumors, cystic neuroendocrine tumors, they did say one of the differentials can be hydatid cyst. And in fact, in that particular patient, I was super excited because, you know, we proposed prospectively that this would be a neuroendocrine tumor. They did a dotatate scan. The only area that lit up was the liver, nothing else, and that came out as well, and that was what it was. But in this case, this imaging appearance is so not like one. So Nelly, go ahead. You can share that article now.
Okay. I would still say MCN prospectively. Anywho, let me. Okay, can we see my screen?
Yes.
Great. Okay, this is the paper that Sudarka, and it was like a Mayo multi-site, and they had surgical pathology with the imaging findings. So they separated MCNs from biliary cysts in the liver, and as I mentioned, has surgical path. And so laterality was not one of those things that panned out to be anything. So even though we're taught, you know, like there's a certain sidedness, it's not actually the case. What did come out to be significant was that septation. So simple cysts, they're unilocular and there's no septations. If they have margins like this, that's also a marker of simple cysts. And if they have septations that go to that indentation at the lobulation, these are great examples of simple cysts. You just done, nothing to do. This is when we start to raise MCN. So it's unilocular and the septations don't go to the lobulated margins, right? It goes, so you got the ball and then the septations go along the kind of the wall and here. So here you have a nice lobulated margin with the septations going to the lobulation, but here you don't. So this is concerning for MCN. And the same thing here. So this is what that case looked like that Anu showed us. A cyst with septations that don't go to the wall with an indentation. And so these were predictive of MCN over simple biliary cysts.
You know, we need to add one more category to these diagrams, figure out how to, you know, the primary cystic hepatic neuroendocrine tumor. This is my first one that looks like this.
It's like, you know, common things being common, right? You know,
yeah, totally.
It's just the prevalence, the pretest probability. I mean, MCNs are, I suspect, probably more common than cystic neuroendocrine tumor.
Totally.
Nelly, I love that you just squashed the laterality myth because I'm looking at the paper. It says for MCNs, 13 were in the left lobe, 6 in the right lobe, and 3 central involving both lobes. So it's still a little bit more predominant in the left lobe, but 1/3 of them at least were in the right lobe. So I think
And
that's a great point.
the other thing that I've read is atrophy, right? You want to see associated segmental atrophy, and that's not actually something that's stood out in this paper either.
Agreed. But the atrophy would also be related to the size, I guess.
Yeah,
Like,
that's true.
if it's a large, so many times MCNs are large lesions when we get to them. So that may be one of the reasons why they cause atrophy.
Yeah, in this paper, it said the median size was 10 centimeters.
Yeah.
They had 22 MCNs and 56 biliary cysts.
Yeah. I've always attributed regional atrophy to either chronic bile duct obstruction, portal vein occlusion, and then a mechanical obstruction by large size. So that was what I had thought, why there is atrophy with MCNs size. All right. Any questions? I have another case to share. Should I continue?
Yeah.
Okay. Okay. So again, woman with chronic pelvic pain, and there was a CT done a while ago, which was non-conclusive, continued chronic pelvic pain. So we got this MR, and let me start with the typical sagittal T2-weighted images. There was a cyst in one of the ovaries, and I was scrolling through the pelvic MR. I noticed the fibroids, Nabothian cyst in the cervix. There was no adnexal masses, bladder. And then I moved on to, didn't particularly notice anything striking. So moved on to
Sorry, there's like some kind of T2 irregular thickening.
Oh my goodness, Nelly, great eye, excellent. We'll come back to that. So
It's just DIE, I think.
Okay, and let me show you the coronals. So
Right there on the right side, and
on
on
the
the left.
coronal,
Yeah.
These things.
No,
Are you
there's some. Yeah, like on the right side, right there above the bladder. There's something there.
here.
Yeah,
So
that dark stuff, and then on the left.
you
there's
have bowel
nodular
loops coming in. Yeah, there are bowel loops coming in. So I think all the black stuff is bowel. What was interesting was there were some cystic structures like this. See this? Tiny T2 hyperintense. These are real non-enhancing cysts on the surface of bowel loops. And then I went back.
Like endosalpingiosis?
Exactly. So I didn't know that diagnosis at that time, but you know how cases from the cookie jar has that case, and I pulled up that case as well for those who haven't seen this entity. So anyway, just completing this case, and then we'll go to the article. There were many small cystic spaces on the surface of the urinary bladder. The case that I'm showing is not as classic as what is shown in the cookie jar cases, but these were distributed. They were mainly in the pelvis. We went back to the CT. CT has very poor sensitivity to detect these tiny cystic lesions in the pelvis. None of them showed any enhancement. I'm going to stop sharing my screen here and then show you the article or the cookie jar case that I brought up, which is more classic. So it so happened that I saw this case a few weeks ago, and then I was scrolling through the radiographics article. Sorry, let me show it to you. And that's when I realized, oh, this is what I saw a few weeks ago. So I went back and added some insight into my report. So I think that what I saw was endosalpingiosis, not as classic as this, but they have chronic pelvic pain as well. And according to literature, these patients can there can be a wide spectrum, asymptomatic on one end of the spectrum and chronic pelvic pain on the other end of the spectrum. And it is also mentioned, these are basically cysts found on the surface of pelvic organs and cul-de-sac. They have been reported on the surface of the bladder, peritoneum, lymph nodes, and skin. which would be very interesting, skin. And then just a minute. Oops. Okay. They are said to possibly give rise to borderline low-grade ovarian serous neoplasms as well. So I don't know if anyone else has encountered a live case of this entity, but I thought this was very interesting. Nelly, do you have my mouse with you? I don't know why I don't have control on my mouse. Here, I'm going to stop sharing.
Lost control.
Ectopic. Can you go back to the MR? I feel like there's more than endosalpingiosis, but I feel like I need to scroll through your case and maybe I'll do that at a different time.
Yeah. All right. I can go through more sequences. This is just, I looked for DIE, if that's what you were thinking, deep infiltrating endometriosis. Like there was some T2 dark stuff here from the fundus of the uterus.
Yeah. Okay. I mean, I think I just need to,
Sure.
It's fine. It's fine.
Yeah, no, let's, if you had more questions, I'm happy to scroll through.
Yeah. Like here on the right side. I like this T2 dark stuff, right? That's not, is that part of the bowel? It doesn't,
No,
like the bowel's right here.
Bowel. Yeah.
And there's this dark stuff here too.
Yeah.
And that's not part, I don't think, I didn't see it communicating with the bowel.
No, that's serosal surface. That's outside. Yeah.
Yeah. So I mean, I would like raise DIE as well, in addition to, I mean, I agree with the endosalpingiosis, but I think there's, there's architectural distortion here.
Right. And burnt out endometriosis possibly because of the age group. This is not.
And then here.
Yeah.
That's all thickened and there's distortion. So I guess I would also raise DIE.
That's a very good point you bring up. Yeah. No, I agree.
Thanks for letting me control your screen.
I also just looked it up, and apparently they're sometimes seen together, endosalpingiosis and endometriosis.
So maybe that's what we're dealing with. The only thing is now they are postmenopausal. So I don't know how much the influence of DIE might be as opposed to, and how these two entities behave in the postmenopausal age. I don't know what the influence of hormones, need to read up a little more. Influence of hormones is on both these entities. Any thoughts, anyone?
Not sure.
Yeah, that's homework for me for next time. I was just excited that I could
teach us.
Sure. I was just excited to make the connection. Oh, this is what I saw a few weeks ago. So, yeah.
I have a companion case to share.
Go for it.
That'll go naturally, kind of with a news case. Okay. Okay. So this is a patient who had pain along the C-section scar in the anterior abdominal wall, lower abdominal wall. And here are the ultrasound images. So we got an MR. And so I can. And we saw the abdominal findings. So here's a C-section scar, the phalangeal incision, excuse me. And there's that T2 dark nodules corresponding to the ultrasound findings at the site of cyclical pain. So this is a great example of endometriosis. You know, I mean, patient has pretty significant adenomyosis, and there's kind of scattered DIE elsewhere, very minor though, very, very little burden. But and it's hard to see the C-section scar, but you can see it much better on the pre-T1 where there's susceptibility artifacts right there. But this is a companion case for abdominal wall DIE. Patient with prior C-section.
Cool. Nelly, is it called DIE if it's in the abdominal wall?
Or maybe
I
not.
I always call it scar endometrioma, but I thought it was like DIE.
That's probably the more appropriate term.
Okay, got it. Nelly, do you want to go with your other case?
Well, that was my case.
Oh, okay, okay. Satheesh?
Yes, I think you should be able. Yeah, you should be able to see my screen. I think this was an interesting case which I saw. So let's have a look at the CT. Patient presents to emerge. It was one of those patients who presented late at night when you think your shift is done, but then you have this and then you're stuck. So have a look at the bowel and see what you think. I'll just scroll down slowly. So that's kind of how it
What is that linear structure in the?
Yeah.
Is it a
So
tube?
It's like a
Exactly.
but the bowel is like all thick around it and like
There's
scrunched up.
intussusception
Is it intussuscepted into? Yeah, exactly.
around the J component or something?
yes. So essentially, that was all the questions I had. Like, first of all, this is abnormal. There's no bowel obstruction. The bowel kind of looked thickened, and I think that my residents and like the fellows thought that it was probably some kind of bowel thickening of some weird nature. And then I think some people thought it was intussusception. And these were all good points. But I think that without knowing more into clinical history, I thought it would be difficult to figure out what it was. So I went and was looking as to what this particular tube is, why was it placed and all that stuff. So it turns out that this is a Duodopa tube. And I wasn't aware at that point of time what Duodopa was. Apparently what it is that for patients with Parkinson's disease, when they take oral Duodopa, the dosing is like however frequent you take it, there is an on period and an off period. So sometimes they're good, but when the action wears off, it's not as good. So instead what they do is that they place a gastrojejunal tube and they administer Duodopa continuously infusion through that so that they have a better control of motor symptoms. So that is what this tube was. So then I had to figure out as to where is this tube supposed to be. So just looking at this is how the tube is supposed to be. It's just a gastrojejunostomy tube, and the tube is supposed to be just beyond the ligament of Treitz here. And this is what the tube was at the time of tube placement. So you can find that it's just this length of tube, and it's just supposed to be barely beyond the duodenum in the proximal jejunum. Whereas currently, this is where it is. It's kind of quite distal here. So that raises a few questions. Now, first of all, how can a tube migrate distally? Because the tube is always going to be fixed at the skin here. At the entry point, they're going to have sutures. So unless the sutures are just like cut off and it's just been totally pulled in, it can't. Or secondly, the tube has to stretch. Now, these tubes are not stretchable. You can't stretch the tube. So the length of the tube inside the bowel is the same. The only thing is that we find that this bumper is ideally supposed to be here. That moved a little bit. So there are a few centimeters that has gone in. But then the tube, which is supposed to be in the duodenum, it just goes on and on and on and on and on and on and on, and it's kind of here. And when we look at the coronal, you're absolutely right. It does look like that could be some weird kind of intussusception. There could be something weird going on here. And didn't really figure out what was going on at this point.
It's not a guide wire, right?
It's not. It's the actual tube. So this is the actual tube, and the whole thing is the Duodopa tube. So I'm like, according to clinical history, the Duodopa tube was also there.
You're building this suspense is killing me.
The later what I did is that obviously I kind of have to see if there are similar cases described elsewhere. And 1 week ago, there was an exact similar case, which I'm going to show you here, with the exact similar presentation. So once again, we have a tube here, and it enters here. The bumper has moved a little bit, but not too much. But then once again, we see that the tube is going on and on and on and on and on, and it just kind of stops here. And we see here a different pattern. This is not really intussusception, because the previous one did look like intussusception, whereas in this one, it does not. But it has this weird appearance. So my point was that the only way a tube can move distally is not that the tube is moving distally, but the small bowel is being scrunched up proximally over the tube. It's like pulling up the arms of a long sleeve shirt or something like that, in which the bowel is actually pulled up over the tube. It's just like we see here, there's
Like an
this
accordion.
accordion-like appearance. Exactly. And it's just being pulled up. And probably that's exactly what is happening here as well. Like the bowel is being pulled up, not the tube being pulled down. But now the question is, why would the bowel get pulled up a tube? Because we place tubes all the time. And we don't ever find the tube distally migrating when it's proximally fixed, or the bowel being scrunched up like this. And that makes not much sense at all.
I have a theory.
So then,
Does the dopamine cause some kind of hypertrophy of the mucosa?
I actually
like
had
bacterial overgrowth?
I actually had something similar like this, because I've seen something similar with the adrenal, like pheochromocytoma, the fat thingy, because adrenal causes like brown fat maturation and all that. So I actually looked up that, but apparently dopamine really doesn't cause anything in the mucosa. So then what I did is that I looked at the product insert of the Duodopa tube as to what are the possible complications involved in that. So among the various complications which has been mentioned is that for some reason, the tip of the tube is more likely to have bezoar formation. And I'm like, okay, that's interesting. So let's just see what's happening in the tip of the tube here. And if you see here, the tip of the tube has this mottled material over it, which doesn't really make any sense. Why should they have mottled material over it? So then putting everything together, what's happened is that, and I actually, all of these are phytobezoars. So then when I looked at other literature to see if it's common, this is something from the literature which I found, in which a Duodopa tube with phytobezoar over it. When they looked at endoscopy, they found similarly what we found. Basically, the tube was being pulled in. They couldn't get the endoscope too much beyond. But because it's being pulled in for a long time, there is the chronic ulcers in the duodenum along the medial wall, wherever the tube has been stretched. So basically, the bezoar formation, it forms a lead point over which the intestinal loops are telescoping behind it. So the tube, like all the bowel loops are scrunched up behind it, and that causes distal migration of the tip. And because now the tube is stretched, this causes all these chronic pressure ulcers and stuff here. And that's exactly the same diagnosis in both of each, in which the phytobezoar are forming the lead point for distal migration. And even here, we can actually find that there is this mottled phytobezoar here. So what they did is that in the first patient, the patient didn't want any treatment and she left. Whereas in this second patient, they tried pulling the tube out and they couldn't pull the tube out because obviously it's just stuck with all this bezoar. So instead, what they did is they cut off the proximal portion of the tube here. And if we look at a follow-up CT, we find that the tube is just hanging. There is no telescoping and everything, but it has been disconnected from the proximal portion of the tube. So here we find that the entry point is here, but after this bumper, it has been disconnected here. And the tube is just now lying inside the bowel. And there is no telescoping because it's the tension on the whole system has been released. In addition, what they did here is that they injected some enzymes, not really injected, but administered enzymes during endoscopy, cellulase enzymes. And because most of these bezoars are known to be phytobezoars, the cellulase can dissolve the bezoar, which allows the tube to be distally kind of transmitted and kind of excreted like via the rectum and stuff like that. Ideally, if the patient's not presenting an emerge, when there is bezoar, they just try the cellulase to see if the symptoms improve and they kind of go from there. Whereas this patient presented an emerge, which a lot of pain and stuff like that. So they disconnected it, administered cellulase, and then this kind of passed off. There aren't any good terms for it. I saw a paper which called it jejunal pulling syndrome. Imaging has never been properly described for this entity at all. It's just known in kind of some surgical literature. I like to call it intestinal telescoping because it kind of seems like a cool term because it's like the telescope sheet kind of being pulled back on the phytobezoar. So yeah, that's my case. Duodopa
Well, if you get a
tube
third case, you'll have a case series and you can coin that term.
Yeah, exactly. I guess it has to be named after me then. But yeah, it was so cool that, and the funniest part is I've been looking out for these cases, but both these cases came within a matter of a week. And I've never been able to see anything before or after that. So yeah, it's just
You're going to
interesting.
get a third one. They always go in threes, Satheesh. So wait for your third one.
Yeah. Okay, yeah, probably I should be able to look out for that.
This is such a cool case. And I don't know if we just don't use them as much. I've never seen one like this. So I'm gonna look, but I've never even heard of a Duodopa. So I wonder if it's, I don't know, just less commonly placed in our hospital.
Yeah, I have never heard about this before I saw this case as well. So when I was looking at it in the middle of the night, when I was looking at it, I had no idea what Duodopa was. So I had to read all about that and can understand what the whole thing was.
And then the other thing is we see GJ tubes all the time without bezoars. So like there must be something about this tube, either the design of the end of the tube or the dopa itself that causes the bezoar or induces bezoars.
Yes, you're absolutely right. Those were the things which I was thinking. I couldn't find a good relation between the Duodopa itself as to why it should cause bezoar. I'm thinking it's probably something to do with the tube design, which somehow attracts phytobezoar, but I don't really know why they have bezoars. But apparently it's known that it's even in the product insert, it mentions that they have a higher incidence of bezoars on them. So it's some, like, I think it's tube manufacturing design or something like that.
I'm really impressed by your investigation, the depth, and then to conclude what you think, which I think you're right.
Yeah, I like playing. I like thinking of myself as Sherlock Holmes when I get one of these cases. You like find every clue, and then you're like, oh yeah, check use. Yeah, that's the diagnosis. It's just fun. These are the cases which keep us going, right?
It's awesome. Okay, anyone else? Okay, I have a couple.
That would be such a great case for unknown compound.
Oops. Okay, this is my first case. Hold on 1 second. Okay, so sorry, I'm trying to make my. So I'll just point out that there's multiple liver lesions. You can't really see them on the T2 very well. And then this is the pre-contrast. There's actually one here, I'll show you in a minute, but you can't really see it that well on the pre-contrast. There's a couple more up here. This is the arterial phase. So we see these couple of lesions up here in the arterial phase. This one here. Another one here. A few more. And then this is the delayed phase. So you don't see those ones very well. You don't see this one very well. So I think somebody was texting in. Let's see. No, I don't see anything in the chat. So what are you guys thinking?
I would put FNH. Do we have a hepatobiliary phase?
We do not have a hepatobiliary phase, but we do have one additional piece of information, which is the in and out of phase.
Within them, yeah.
And so here's the in and out. Hopefully you can see it pretty well. But so we can see that the liver is fatty. And just looking at this dominant lesion here,
there's no dropout in that, right? It doesn't look like this.
Well, that's one question. That's a question. So
Yeah.
Is there dropout? And I would say that actually there probably is dropout. So, and I can even measure it for you. But for example, like the lesion itself is heterogeneous. And sometimes if the lesion has fat and the liver's fatty, it's hard to tell. But when we measured it, there is actually fat in the lesion as well. See here?
Yeah, I can see now.
So what do you guys think? Previously it was thought this could be an FNH.
I mean, you would have to throw in HNF1 alpha adenoma.
So
And
that's my question. So it's going from 375 to 315 with a standard deviation of 20. So it's dropping at least 2 standard deviations. So there is some fat in it. But otherwise, it was looking very FNH. They were looking very FNH-y, right? So that's the question.
I've seen a case where, wait, there was like oh no, never mind. Sorry.
Combination of both.
Combination. Yeah, but
because it's also considered to be on a spectrum, right? These entities.
Yeah. So the question is, can FNH have fat? And I brought this up here before. I've also brought up this.
I think that FNHs can have fat, right? Especially in the setting of fatty liver.
Exactly. So this paper I brought up before, but this French group, they actually looked at a whole bunch of their FNHs. I think there was resected FNHs with intralesional steatosis was 25 of them. And basically their conclusion was that FNHs can have fat. And on MRI, fat within a typical FNH should not reduce your diagnostic confidence. So the fact that this lesion was stealth on the T2 and the T1 pre and was very lobulated, homogeneously arterial enhancing, all of that was very classic for FNH. Mm-hmm. And even if it has fat in it, that should not reduce our diagnostic confidence. And then I do have one more example of, here is an example of, if we can, this is a lesion that was an FNH that also had fat in it. So this is the in phase, this is the out of phase MR imaging of a fatty FNH. So in the end, actually, this was called a fatty liver and fatty lesions, and they were called adenomas. And this large one was resected and turned out to be an FNH. So I guess the teaching point is that FNH can have fat. This is a biopsy proof or a pathology proven one. And especially if the background liver has fat, and that makes sense to me because basically the FNH is a proliferation of, normal but disorganized hepatic tissue. So the same way that the fat is getting deposited in the fatty liver, it can also get deposited in the FNH. So if it looks like FNH on all other sequences, at least bring it up, maybe recommend EVIS, but don't just jump to the, adenoma.
Nice. There's no term for multiple FNHs, right? Like you have adenomatosis for multiple adenomas.
No, but actually I think FNHs are quite common, and it's the second most common liver lesion. Yeah. It has a prevalence of like 4% in the population, and it's actually 10 times more likely than an adenoma. And they're both also more likely in younger patients as well as female patients. So yeah, I don't know a term for multiple FNHs, but I wouldn't be, and also you could have FNH and adenoma coexisting, especially in young women, so. Okay. That's
a great case. This is what, at least like back during my fellowship days, and like even here, what we always consider is exactly what you said, as in percentage of adenomas with fat is much higher than percentages of FNH with fat. However, in the population, FNHs far outnumber adenomas. So when we see a lesion with fat, it's almost equal that the likelihood of it being adenoma versus FNH. So just based on fat, we really shouldn't consider, especially if there is fat in the surrounding liver as well. Or at least that's how I've been taking this to be.
Yes, agree. And that's the same kind of thinking, I think, with like atypical or sclerosing hemangiomas. Like they are rare, but hemangiomas are so common that some of them are going to end up sclerosing over time or be a little bit atypical, et cetera. So I don't know, just always think about them just based on like their prevalence. Okay, this is a second case. There is a lesion here in the kidney. It's got, multiple components to it, septations. I'll show you the venous. You can see enhancing septations. It's involving the renal pelvis.
Renal rest lesion.
Renal what?
MEST, you mean?
Yeah, Nelly, why did you say MEST?
didn't Anu or somebody
Yeah.
else like presented a case
Yeah.
of this before, like, or something similar?
Yes. Yeah. Yeah.
Was that you, Anu, or was it?
Yeah, that was me. I showed you guys a
Rupa?
MEST, a large MEST.
Mm.
You know, these lesions, they tend to protrude into the renal sinus fat, and they are multicystic, almost like a Bosniak 4.
But, okay, so when I hear all of that, I think about multilocular cystic nephroma, or MCN.
Yeah.
Which herniate into the renal pelvis. They overlap with Bosniak 3. They have multiple septations. They're seen in like young boys and middle-aged women. MEST tumors are mixed epithelial stromal tumors. They tend to be more solid with cystic components, etc. I think there may be some overlap between them, but interestingly, this one turned out to be a MEST tumor. And we said, you know, could be an MCN, could be a cystic RCC, not sure. And they removed it and it was a MEST, which is also a benign tumor. Both of them have like a significant female predominance. MEST tumors are actually 10-to-1 female to male, and then also tend to be middle-aged. So I don't know what to say about this. I would have brought up MCN. I think either way, often these get resected. Both of them are benign lesions, but this one did turn out to be a MEST tumor. And in fact, this wasn't a male. So even if it's 10-to-1, that doesn't mean it's impossible. So
when, I mean, we would still apply Bosniak, right? Or no?
Yeah. And this didn't have any solid components, like solid nodular components. So I think this still would have been a Bosniak 3.
Did they follow this at all, Aarti, or was it
actually had grown? It had grown over a couple of years.
Yeah. So I've noticed that as well. We've done the same thing, like had things come out and go one way or the other. That it's very difficult prospectively to distinguish MEST from a cystic nephroma or, you know, cystic RCC. And they, like, at least the ones that I've seen, they tend to increase in size and then they come out eventually. And that's when path really tells you which one it is.
Yeah. So it seems like, you know, unfortunately, these are still usually resected, but good for the patient. It's a benign thing. So, and it doesn't really look like a cystic RCC in that, like, it's not, you know, like a circular mass, you know, it looks more like a multilobulated thing, but yep.
So is it also sorry, go ahead.
Sorry, yeah, we were talking about the pathology of this as to how cystic nephromas are different from MEST, right? So my understanding of this, and I actually spoke with a pathologist regarding this exact question a few months ago, because once I wanted to get a case of cystic nephroma, and I was just looking at case after case of pathology, and every single cases were called as MEST. So then I called the pathologist at some point and I asked them, and we were discussing about this. So prior to, I guess, like 2012 or 2010 or something like that, almost everything was called cystic nephroma. But then later, just like pathologists used to do, they kind of shake up everything as soon as we get comfortable. So all of these are now under a spectrum of entities which are called MEST. So cystic nephroma is a component of MEST. There is another, like I think a juvenile form of cystic nephroma, which is considered a little bit separate, but all the adult cystic nephromas are considered in one end of the MEST spectrum. It's very similar to how AML is considered a benign end of the spectrum of PCOMA. Similarly, cystic nephromas are considered, so the 2016 WHO classification actually includes cystic nephroma within the MEST family. So the pathologist, I think at least in our institute, they don't ever give cystic nephromas a differential anymore. They just say it's a MEST tumor, and all of these are called MEST. So whatever held good for us previously for cystic nephromas, in which we said it's multilocular, it protrudes into the renal sinus and all that, is actually cystic nephroma, which is the benign end of MEST. So the pathology report is always going to be MEST in these cases. And
what's the malignant? I mean, when you say spectrum, it makes me think of something benign and a malignant spectrum. So what would be the malignant spectrum component of MEST if this is a MEST is benign?
So that's the thing, like MEST is never actually totally malignant, but I think the issue was, I don't really know very much about it, but it's just that it could be a little bit more aggressive in some variant. It's never, I think it can be a bit locally aggressive in the more aggressive thingies, but I'm not 100% sure about that. But essentially, like the most benign, or like when certain diagnostic characteristics in pathology are satisfied, they can call it a cystic nephroma, but they never do it. They just call it MEST these days. MEST can also have ovarian stroma in the stroma, which is kind of similar to the ovarian mucinous neoplasms or the similar neoplasms of the liver, in which you have the ovarian stroma. So I somehow think that there is something common to ovarian stroma in MEST versus like the MCNs in the liver and the ovary and all that stuff. So there's something unifying all of them. In regards Bosniak 3 and 4, unfortunately, they are either Bosniak 3 or they can have solid component and they look like Bosniak 4. And more often than not, they end up being removed because not a lot of centers actually do active surveillance for these ones. And in terms of imaging differentiation with cystic RCC, I don't know if there is a way to differentiate that, because in cystic RCCs, there is an entity which is called multilocular cystic neoplasm of low malignant potential, which currently is considered benign, and they can look almost exactly like this. And there have been enough cases which actually protrude into the renal sinus as well. So I don't think there's a very good way to differentiate. The only thing, again, this may be incorrect, but I somehow find that in the corticomedullary phase, cystic RCC, all the septa and everything kind of hyper enhance very, very well, whereas MEST enhances a little bit less, but it's not something very reliable. So there's an overlap there. So clinicians in my institute, what they do is that if it is a solid renal mass, then there is a chance it could be an oncocytoma or a fat poor AML. So then they biopsy it. But if it's cystic mass, it's either a cystic RCC or a MEST, which currently they still more often than not take it out, especially when the patient is younger. Even an older patient they may consider, but in a younger patient, especially in this patient, we find that it's causing hydronephrosis and stuff like that. So more often than not in a younger patient, if it's a cystic mass, they don't wait for a biopsy, they just take the lesion out because it has to come out anyways.
Satheesh, that was awesome. And
Professor
Satheesh. I was very confused about the MCN MEST overlap. So that was super helpful. And now I feel better about the fact that this to me looks like an MCN, and apparently that's in the MEST spectrum. So the pathology came back MEST. That makes a lot of sense. Thank you. That was really awesome. And I had one more quick case. Show you guys quickly. Okay. I'm going to try to show this ultrasound. I'll just focus on the upper quadrant here because I don't want to show any more of the ultrasound, but do you see that there is a lesion in the fundus of the gallbladder? And it's got a couple of little echogenic foci in it. And it looked mass-like. So we said this could be fundal adenomyomatosis or a gallbladder malignancy. We recommended MRI. And then this was the MRI. So that was the lesion. You've got like a little cystic space here. There's some tiny little cystic spaces here with some T2 dark areas. And then this is what it looked like on the post contrast, where you can see the mucosa is kind of nice and smooth over it. So we thought this was adenomyomatosis, and that these are the cystic spaces like the Rokitansky-Eshel sinuses, and then these dark areas are like the hypertrophied muscle, and this nice smooth mucosa over it was also kind of confirmatory that this was not a malignancy. So I just thought it was a good, nice example of what it can look like on ultrasound. And then these little echogenic foci are probably like the cholesterol in the sinuses.
Very nice.
Okay, I managed to not share anything on the ultrasound. Anyone else have anything else? Or? Okay, have a great day, guys. See ya.
Thanks, everyone.
Thank you.
Yeah, great day.